Hi everyone. Can everyone hear me? Can I get a feedback? Am I audible to all? Good evening. Hi everyone. Okay. Okay. So good evening guys. Myself Dr. Jisha Jain. I'm a Pharm D graduate. I have been working as a faculty in Pharma International Institute and I'm a pharmacist too. So today I'm here to take class on the topic estrogen and androgen. This is a live demo class for you guys. Okay. So we'll be learning about what is the action of estrogen, what is androgen, what are progesterone. Okay. So I think, yeah, everyone has joined. Good evening to all. Okay. So yeah, let's start the topic. So everyone knows, like, being a human, you need to be either a male or a female. I mean, the God has made us in a male and a female version, right? So being a male, how can you say that, yes, I'm a male? Or how can a female say that, yeah, I have a female characteristic? We need the sex hormones, right? Those are the endocrine hormones that is playing an important role for developing the female as well as the male reproductive organs and the sexual characteristics, right? So the first thing we'll be learning about the estrogen. Okay, how estrogens are produced, how progesterones are produced, and how androgens play an important role. What are the different anti-androgens? So all those things we'll be learning one by one. Okay. So as I said that humans are classified as, I mean, they are classified as male and female. So males, they have which like sex hormones, obviously the testosterone. So those are the main androgens present in the male body. But yes, it is present in the female body also, but a small quantity, right? Same way goes for the female. Females have what? They have female sex hormones, that is estrogen as well as androgen. But yes, small amount is present in the male body also. Okay? Yeah. Okay. Now, what happens? So the first thing, how this estrogen and androgens, these are produced. Okay. So obviously from the hypothalamus, this gonadotropin releasing hormones are produced. That is GnRH. You would have heard about this gonadotropin releasing hormone. So these from the hypothalamus, it stimulates the production of the gonadotropin releasing hormone, which then like stimulates the pituitary gland. Okay. It will say, it will stimulate the pituitary gland to produce two important factors. One is the FSH, which is the follicular stimulating hormone, and the LH, which is the luteinizing hormone. So these gonadotropin releasing hormones, these are stimulating the anterior pituitary. Okay, there are two pituitary part, right? Anterior and posterior. So the anteriors, they will be producing the follicular stimulating hormone and luteinizing hormone. The posterior pituitary, there are two hormones, vasopressin as well as oxytocin. Okay, so yeah, so we are learning about the estrogen and androgens and the progesterone. So we'll be focusing on the anterior side, that is your follicular stimulating hormone as well as the luteinizing hormone. Now what happens? These follicular stimulating hormone, they will stimulate the ovarian follicles. I mean, inside the ovary, you know, the follicles are present. Every month, a follicle will become dominant. It will rupture. Then it will form the corpus luteum. Menstruation might occur, or if fertilized, the embryo development might occur. So that is something. The follicular stimulating hormone, it is going to stimulate the ovarian follicles. Once the ovarian follicles are stimulated, the granulosa cells, which is present in the follicles, they will produce the estrogen, the main sex hormones in the female. Coming to the other side, the luteinizing hormone, which is also produced from where? From the gonadotropin releasing factor or the hormone. From that, this luteinizing hormone will be produced through the corpus luteum. Now, what is this corpus luteum? After the menstrual cycle, you know about the follicular phase, luteal phase and all, right? So what happens once the ovulation has occurred? After the ovary follicles have developed, there is a dominant follicle which will rupture, okay, and they will release the ovum. And that ovum will travel through the fallopian tube and then it will reach the endometrial lining area. Okay, so that is a normal thing. Now, once the egg is removed, from the ruptured follicle, the egg is it has come out. What will happen? The debris or your remaining particles, that is it will form into a degenerative corpus luteum. And that corpus luteum, it will be converted into corpus albicans. Okay, so you can say that albicans, the corpus albicans. Okay, so that is what happens. From that, this corpus luteum, what they are going to do, they are going to stimulate the release of progesterone. Okay, so that is the main two factors, estrogen and progesterone. These are important for the female reproductive cycle, for the menstrual cycle, for the development of pregnancy, for the embryo development. For every cycle, we need estrogen and progesterone, right? So that is after the corpus luteum has been, the degenerated particles has developed, that is forming the corpus luteum, and that will increase the release or the production of the progesterone. Okay, so this is just an idea about how the estrogens and progesterones are produced. Okay, coming to the first one, that is estrogen. So I already have told you it's a important, most dominant kind of female sex hormone. Okay, now there are natural types of estrogen also, which is there in our body itself. The three important natural estrogens, that is your estradiol, estron, as well as the estriol. Okay, now what happens, always remember, these estrogens, these are also derived from the androgens. Okay, from the testosterone, or you can say from the androstenedione. These are the precursors of the androgens. From this, you can get these three natural estrogens. That is your estradiol, estron, as well as the estriol. Okay, the most dominant one among this natural estrogen is the estradiol. Okay, now what is that estradiol? It is a major estrogen secreted by the Graafian follicles, corpus luteum, and placenta in females, and also by aromatization of testosterone in the testes. Apart from that, with the help of extraglandular tissue, these are seen in the male's body. Okay, so this is the most active and potent type of natural estrogen. Now, I have already told you these are produced from the Graafian follicles, that is inside the ovarian follicles. The Graafian follicles, they will produce the natural estrogen, that is the estradiol. Apart from that, from the corpus luteum, the degenerative segment, okay, from there also they are going to produce the estradiol, and the placenta during the pregnancy stage. So that time also estradiol can be produced. Now coming to the male body, how in male body from the testis, how this estradiol is produced, that is aromatization. That process is known as aromatization. What happens, you see in this part, so these are the two precursors, that is testosterone as well as the androstenedione. Now androstenedione, it can be converted into the estron. Estron is a E2, you can say, that is 1, E2, E3. Okay, just for your understanding. So estron is something which is produced when there is an oxidation of the estradiol. Estradiol, it is oxidized and it is going to form the estron. And this is something which is active in the postmenopausal woman. In the postmenopausal, after the menstrual cycle, after a certain age, that is around 50 age, okay, or 45 plus age. So there will be a post-menstrual period. So that time, this oxidized form of estradiol or estrogen, that is the estron, will be produced. Okay, and then with the help of hydroxylation reaction, this estron, when it undergoes hydroxylation reaction, it converts it into the weak form of estrogen, that is your estriol. Okay, so it is formed by the hydroxylation of the estron. This part is the natural estrogens. Now come back to this part. So the androstenedione, it can be converted into the estron. So this is something, in this place, there is one enzyme which is helping for this conversion. There's a friend who is helping for this conversion of androstenedione to estron. What is that? The aromatase enzyme. Okay, it's like a aromatase enzyme means there will be aromatic ring in a benzene ring. A benzene ring structure will be there. What happens? This, if it is from the testis, okay, from the testosterone, it is converted into estrogen. So when there is an aromatic ring structure in this testosterone structure, what will happen? It will form the estrogens property. It will enhance the estrogens property. Okay, so that is your androstenedione's action with the help of the aromatase enzyme. Okay, aromatase A ring. There will be one A ring structure. Okay, that's a benzene ring structure will be there, and that it will help for the conversion into estron. Then this estron, what it will do? It will be converted into estriol. How? I have told you, right? The hydroxylation reaction. So from estron to estriol, we are getting from the hydroxylation reaction. So that is one part. Now, this testosterone, that is also precursor, that is converted into estradiol. That is from an androgen, it is totally changing into a estrogen. So here also, this aromatase enzyme is playing an important role. So that aromatase enzyme, that is aromatase ring structure will be there. That is going to enhance the estrogen's activity. Properties of estrogen will be enhanced. So thereby, androgen will be converted into the estrogen. Okay. So that is the whole cycle. And in between, according to the metabolic needs of the body, this estrone as well as the estradiol can be interconverted. Okay. So that is, I have told you, the ring ACE aromatization reaction is occurring there. Okay. So that is all the three important natural estrogen. The one estradiol, that is something I have told you about. It is mainly produced by your Graafian follicles, placenta, as well as corpus luteum. This is something which is estrone, that is mainly up. It is also potent, but it is less potent form of estradiol. Okay. And yeah, from the hydroxylation reaction, you get the estriol. Okay. So this is the natural estrogen part. Coming to the synthetic estrogens. Now, what do you mean by synthetic estrogens? We have two types of synthetic estrogen, steroidal, non-steroidal. Steroidal means these are the hormones or the synthetic form of the natural estrogens. Okay, they have similar structure to that of the natural estrogens, and yes, they are going to enhance the effect of the natural estrogen. That's why those are the steroidal part. The non-steroidal part, those are totally different, oppose partners. Okay, they are opposing, but yes, they are also having the similar feature, that is non-steroidal. This estrogens, what are they? They are going to have different structures. They will be totally different from the natural estrogen, but yes, they are going to mimic to bind to the receptor, that is the estrogen receptor. Estrogen normally has two receptors, okay, for the binding. That is estrogen alpha receptor and estrogen beta receptor. Now, this is normally both these receptors, no, they might be present in different parts of the body. Especially if you ask me, the estrogen alpha receptors, these are mainly present in your ovaries, vagina, breast area, okay, hypothalamus, blood vessels, okay. Whereas beta estrogen receptors, these are mainly seen in the ovaries, testes, okay, the Leydig cells, okay. So that is some of the important points. Now, coming to the steroidal, we have the one most important synthetic estrogen, that is a synthetic estrogen derivative, ethinyl estradiol. What is that? The most potent, you can say, or the advanced version of the natural estrogen. Next, we have mestranol as well as the tibolone. Tibolone is something, the weak factor. Weak, the synthetic estrogen. Okay. Now, ethinyl estradiol, that is something what they can be used for contraception. Okay, for termination of pregnancy, that is for as a contraceptive method, it can be used in combination with progestin. Okay, the progestin derivative, progesterone derivatives. So that is something what they are going to do. Ethinyl estradiol, they will prevent the ovulation, whereas your progestins, what are they going to do? They will alter the cervical mucus so that the sperm cannot reach the ovum for the fertilization. Okay, so that is the partnership they are maintaining for contraceptive methods. Coming to the non-steroidal, which has different structures, but yes, they are going to mimic the binding site for that estrogen. Okay, they are going to bind to that estrogen receptor. Diethylstilbestrol, that is simply you can say DES. DES. Diethylstilbestrol, or simply the stilbestrol, then hexastrol as well as the dienestrol. Okay, so those are some of the non-steroidal kind of estrogen which are present. I mean, those are synthesized. These are something which are synthesized in a laboratory, not in a real body setting, but yeah, in a laboratory setting to enhance the activity of the natural estrogen. Why? Because this estrogen, the natural estrogen, they don't have 100% oral bioavailability. That is one of the the negative thing which is there for the natural estrogen. Okay, because of the first pass metabolism, they don't have a good bioavailability. Okay, so that's why we are enhancing this to get that 100% bioavailability if you give it with the oral administration. Okay, so that is the main point. Next, ethinyl estradiol, because this is the main hero of this particular estrogen derivatives. Okay, so yeah, we'll learn about the ethinyl estradiol. Given orally at a low dose to substitute the level of estrogen in the body. If after a certain age, as you know, let's say in the female itself, After a certain age, there is a decrease in production of estrogen. Okay. So if there is no estrogen production in the female body after a certain age, let's say after the postmenopausal state, okay, you know, estrogen is important factor for so many functions. Okay. One of the major drawback if there is deficiency of estrogen is what? Osteoporosis. You would have heard that like postmenopausal women, they are at higher risk of getting osteoporosis, or you can say getting this fractures issues. Why? Because estrogen that is required for increasing the what? Bone density, bone mineral density, BMD. Okay, for increasing the bone mineral density, you need estrogen. If there is a deficiency of estrogen, what will happen? The bone will get degenerated. The osteoclastic activity, okay, osteoclastic activity will be enhanced. That is, the degeneration activity will be there. The bone will become less dense. Fracture might, like there is a high risk of getting fracture. So that is one of the major drawback if there is no estrogen. So obviously, we have to supply the estrogen to our body if there is no estrogen there in your body, right? So that's why we are giving the synthetic form of estrogen with a good bioavailability, oral bioavailability. So that's why it is given orally to substitute the estrogen level in the body. Next, patient with the risk of endocancer, that is what? The endometrial cancer. It gave estrogen with progesterone. Now, why is it so like that? Why can't you give it estrogen alone? There is a reason. Estrogen, see, it has a positive impact, but it still has some negative impact also. Estrogen, what it can do, it can trigger the development of cancer. Receptor-based cancers, that is your breast cancer, your endometrial cancer. These are the major issues if there is a large amount, if there is so much of estrogen, if it is there in the body. So too much is also not good, less is also not good. Okay. So now what happens, if you give estrogen alone, it will trigger the proliferation of the cells in the endometrium layer or the breast tissues layer. So because of that, there will be a chance of endometrial cancer. So to prevent that, you're giving a partner to that particular estrogen, that is your progesterone. Now this partner, what it will do? It will suppress that proliferating action of this estrogen. Okay, let's say this is someone who is very aggressive. So he has got a partner who is a calm person. Okay, so you will have this, the person, even if he is to aggressive action, so the person who can calm him down, that maintenance can be there, right? So that is a way. So that's why give estrogen with progesterone to suppress the proliferating actions of the estrogen, right? Next, uses. What are the uses of this ethinyl estradiol? The main use is contraception. I've told you, estrogen derivatives, it is given with progesterone derivatives for what? For enhancing the contraceptive issue. I mean the problem, as a contraception. Okay, for delaying pregnancy, for like a termination of pregnancy. Different factors are there, which we'll be learning in the contraceptive part. Okay. Apart from that, for hysterectomy, give alone. In all other cases, use in combination. Why is it so? So, estrogen, let's say, 2 patients are taking. In one patient, that woman has an intact uterus in her body. Hysterectomy, you know, right? The removal of the uterus, cervix area. So, one side, a patient is having uterus intact in her body, and the other person has gone for the hysterectomy and doesn't have any cervix uterus area. Okay. Now, if the patient has undergone hysterectomy, that is the post-operative stage person, that woman doesn't need this progesterone. Okay, why? Because there is no uterus. Okay, so there is no like supportive treatment needed for that uterus protection. Whereas if the patient is having intact uterus in her body, there might be chance of what? The endometrial cancer to occur. So that's why in such condition where the woman is having the intact uterus, you have to give a partner, that is progesterone with ethinyl estradiol. So those are some of the important points. Now, what are the different side effects of estrogen? In different population, we have different types of side effects. Now, in males, what happens if there is a estrogen level, increase in estrogen level? Suppression of libido, gynecomastia, and feminization. What is that? Suppression of libido. Because of the increase in the estrogen level, there might be imbalance in the androgen and estrogen level. Obviously, the males, they need androgen level because they have one aggressive kind of nature. Not everyone, okay? Yeah, but they have this muscle build-up. They have the pitch tone is very deep, okay? They have beard, mustaches, everything. So that is a characteristic of a male, right? So if there is more estrogen acting in the male body, there will be suppression of libido, sexual drive. okay, for sexual drive in a way, like for while having sexual intercourse, they won't get that pleasure. So that is the suppression of libido. Next, gynecomastia, development of breast tissues. Androgen level is decreased, estrogen level is increased. That will start developing what? The breast tissues in the male body. That is something the gynecomastia. And finally, we have feminization, the feminine characteristics. Like as a girl, what is the characteristic of feminine? I mean, they'll have long hair, the fat deposition in different parts of the body, like in breast tissues, in the hip area, in the thigh region. Okay, they have a feminine structure. So that thing, or the like pitch sound, the low sound pitch, or all those things, the female characteristics will be seen in the male body because of this like fluctuation in the estrogen level. Coming to the children, fusion of epiphysis and reduction of the adult stature. There is an epiphyseal plate, that is a growth plates in between the bones. There will be some joints, that is a growth plates. So that will suppress that fusion of the epiphysis, or before the growth occurs, that suppression, that blocking of that epiphyseal plates will take place. So they will have stunted growth. They won't develop that height because of that estrogen malfunctioning. Okay. Next, PMS, post-menopausal woman or patient who is in hormonal replacement therapy, HRT. Hormone replacement therapy means what? We are giving estrogen supplementation or progesterone supplementation if there is a deficiency. So in such patients, there's a risk of irregular bleeding and endometrial carcinoma. Not only this, they will have this breast cancer also. Okay. There is a high risk of DVT. What is that? Deep vein thrombosis, the blood clot. From the lower body parts, in the deeper veins of the legs area, there will be, the clot formation, and then it will embolus, deep vein thrombosis, that is the pulmonary embolism might occur. It might develop into what? The pulmonary embolism. So those are something which can be seen if there is a more estrogen activity or there is a malfunctioning. Okay. So in this patient, PMS woman, there might be irregular bleeding. Menstruation won't be proper. Imbalances will be there because of the imbalance in the hormone level, and there's a risk of endometrial cancer. That is, receptor-based cancers will be developing. Next, existing breast cancer. Already the patient is having such issue. Then what will happen? They will enhance. More proliferation of the breast cancer will take place, and that might be life-threatening. Under long-term estrogen therapy, increased incidence of gallstones, benign hepatomas. The liver, there will be stones in the liver. Okay, hepatomas will take place, and there will be increase in the gallstones. Okay, there will be cholesterol deposition will be there in the bile. Okay, because of that, because of why? Because of the estrogen more activity. Next, comorbid condition. Already the patient is having migraine, epilepsy, endometriosis. Already the patient is suffering from so much issues, and still the one more person comes to this group and says, okay, let me also have some fun. And then that estrogen, they are going to enhance, they are going to increase the blood supply to the cerebral flow of the blood, and then it will what? Increase the migraine activity. That is also a side effect of estrogen. Same way, epilepsy. Why? Excitatory action. You know, right? In central nervous system, we have inhibitory excitatory neurotransmitters, right? Glutamate is a common excitatory neurotransmitter. Right. So that is what they're going to do. Estrogen, they can enhance the excitatory action that can increase what? The epilepsy, seizure attack. Okay. Finally, endometriosis. Already there is a degeneration of endometrium. There is a development, proliferation of the endometrium lining. The cells are developing. So it is the what? Again, estrogen is coming and trying to modulate that area. What it will cause? Worsening of the condition. So those are some of the side effects of estrogen. Now, how to treat this particular condition? As I said, obviously, we have to give this estrogen, right? Anyhow, we have to give the estrogen supplement to the patient. Why? If not, there might be some side effects for that also. Some kind of problems might arise. So how can we solve this problem? So here comes the hero for this particular estrogen side effects. That is your SERM, selective estrogen receptor modulator, SERM. Exerts both estrogenic and anti-estrogenic action in the tissue selective manner. Very important point. What it does, the name itself has selective estrogen receptor modulator. Selectively, you have estrogen receptors in different parts of the body. These particular drugs, they will selectively go and either they will inhibit, or that is they will either block the activity of estrogen, or they will mimic and increase the activity of estrogen. Two activities, either mimicking or the blocking activity. Agonist, antagonist activity. So that is the thing which this SERM is showing. Okay. Now, in which receptor they should act as a agonist and which receptor they should act as an antagonist, it depends upon the type of receptor they are acting, for what type of condition they are acting. Now let's give some example, that is these are the different types of selective estrogen receptor modulator. The first one, tamoxifen, prophylactic to treat the BC. It's not something before Christ, that is breast cancer. Okay, so prophylactic or treat breast cancer, for that you are giving tamoxifen. Now I have told you that we are giving it half, either it's agonist or antagonist or both, but different receptor. So what it does, it will act as an antagonist at the breast tissues and partial agonist at the uterus. Why? Why they are okay? They can just act as an antagonist at the breast, right? Then why to give it as an agonist in the uterus? To enhance the uterus activity, for the proper maintenance of the uterus. Okay. So for that, tamoxifen, one side for the treatment of breast cancer, it is given as a breast cancer, right? So for the treatment of that, it is going to block the activity of estrogen at the breast tissue. Whereas one side they are giving problematic, thing, that is what they are going to treat the condition. One side they are going to give a gift also, that they are going to show some agonist activity. They will increase the amount of estrogen so that uterus get benefited from that. Metastatic breast cancer following mastectomy or radiation, stage 4 kind of breast cancer. For that also, tamoxifen can be given. Why? To treat that breast cancer by reducing, antagonizing or blocking the activity of estrogen at that receptor. Okay. Raloxifene. So this particular is a unique characteristic it has. Not unique, everyone has a unique character, but yes. Why raloxifene? One side, I have told you, right? Bone also need estrogen to enhance the mineral density. So this raloxifene, what it will do? It will go and act as an agonist at the bone tissue, and it will serve some estrogen so that the bone density might increase. On the other side, in case of breast, they are going to act as an antagonist. Similar action for the antagonism in both tamoxifen and raloxifene, but as an agonist action, they are showing in different receptor. So yeah, see, it is acting as agonist at the bone tissue so that there will be more amount of estrogen. It will help for maintaining the bone mineral density. And so we can prevent this osteoporosis, your Paget's disease, all those kind of bone disorders. Okay. One important point here, cholestyramine decreases the absorption of raloxifene. What is that, cholestyramine? Bile acid sequestrant. It's bile acid sequestrant. What it does, it will go and bind to the bile juices, okay, and it will not allow the reabsorption of bile into the body. So to remove the cholesterol from the body, for if there is a high level of LDL, okay, to reduce the cholesterol level, this bile acid sequestrant is playing an activity. They will not allow the reabsorption of this bile into the circulation. Now what this raloxifene does, it depends on this cholestyramine for the absorption into the bloodstream. Okay. What happened? This person needs a friend for the absorption and reach the circulation. If this cholestyramine, what it will do? This bile acid sequestrant, it will remove all the bile, okay, and so that raloxifene, who is depending on the bile juices for absorption, there is no free bile present, right? So what will happen? All this bile has been taken from the cholestyramine and it is excreted out of the body. Now there is no free bile juice available for the raloxifene absorption. So thereby it will decrease the absorption of raloxifene. That is what cholestyramine does. Next, bezodoxifene. Antagonist at the endometrium. Why? Antagonist blocking the activity to prevent the endometrial cancer. Okay, and same way, it can act as an agonist at the bone tissue also for the proper generation of the bone mineral density or the bone tissues if the patient is having some bone disorders, for them you can give. Next, clomiphene. That is, these all are types of SERM, okay? Keep that in mind. Partial estrogen agonistic change, clomiphene. Many of the patients, females, they are suffering from this commonly called PCOD, infertility issues, PCOS, okay? So in such patient, to enhance this ovulation, for the proper menstrual cycle regulation, clomiphene can act. So they can have this agonistic activity in the uterus, or you can say for the menstrual cycle regulation. So for the PCOD issues and all, this can be given. It can be a help. Next, ospemifene, dyspareunia, painful intercourse treatment. Why dyspareunia? Estrogen, it has many advantage if it is there in the human body. Okay, in women's, after a certain age, let's say after a postmenopausal stage, there is a decreased amount of estrogen supplied to the body or to the uterus area or the vagina area. Okay, because of that, the lubrication or the mucus secretion will be decreased. There won't be any proper mucus secretion, or your lubrication won't be there. Why? Because of the less estrogen. So because of that, dyspareunia can occur while having sexual intercourse. The painful intercourse. Why? Because there is no lubrication present. So for that treatment also, ospemifene is given. Why? This will go and trigger the proper lubrication, mucus secretion in the genital area. Okay, thereby it will help for the treatment of this dyspareunia. So I hope this chart about the selective estrogen receptor modulator is clear. Okay. Next, jump into the other friend of estrogen, that is your progesterone. Okay, so both are working together like besties. Okay, so they are working together to enhance the effect of the body's ovulation step, whatever female characteristics it has. Same way as an anti part also, that is anti-estrogen, anti-progestin. These are given for what? For the contraceptive methods. Now, what is progesterone? This is also a female sexual hormone, sex hormones. It is a main endogenous steroid hormone produced in the ovaries, testes, and adrenal glands, involved in the menstrual cycle, pregnancy, embryogenesis of humans. So for all the steps after the ovulation, from the corpus luteum, this is produced, right? Progestins are produced from where? From the corpus luteum. So what will happen? In the ovaries, after the ovarian follicles has shed or the ruptured, they will release the corpus luteum, they will convert into corpus albicans, and then they will produce the progesterone. Same way in the Leydig cells of the testis, from there also it can be produced. Adrenal glands, like in case of testis, there might be from this 19-nor-testosterone, okay, nandrolone, from those parts that is deriving the progestin. Okay, now these are also involved in the menstrual cycle for the proper luteal phase, ovulation phase, follicular phase. For all that maintenance, we need progesterone. Progesterone is also important for metabolic intermediate in the production of other endogenous steroids, glucocorticoids, mineralocorticoids. For all the steroids production also, this progesterone can act as a precursor. You can say it as a precursor. Next, sources of progesterone, site of synthesis. So in females, the corpus luteum, that is at the early pregnancy stage. Okay, after the ovulation, at the early pregnancy stage, during the first trimester, this from the corpus luteum, they will produce this progesterone. Then from the placenta, for the embryo development, from the placenta, that is in the late pregnancy time also, they will produce progesterone for the development of the embryo. Okay, for the fetal development. And finally, from the adrenal cortex. Same way goes for for the male, testis as well as the adrenal cortex. So those are some of the sites from where the progesterones are derived. Coming to the classification. So the natural classification, natural progesterone, that is what? Your medroxyprogesterone acetate, megestrol acetate, then dihydrogesterone as well as hydroxyprogesterone caproate. Those are the progesterone derivatives. What do you mean by derivatives? Natural progesterone derivatives. Okay, they have structural, those are the natural kind of derivatives of the progesterone. While coming to the synthetic types, so we have one old classification, new classification under the 19-nor-testosterone. Here, some important differentiation part is that in case of this old classification of the 19-nor-testosterone, there will be more androgenic activity. Okay, more activity of androgen means what? There is one of the main side effect in this particular classification is the acne. Weight gain, acne, those are some of the main symptoms, or you can say the side effects of these particular classification. Why? Because they have more androgenic property. Whereas the one which is having less androgenic property, that is your desogestrel, norgestimate as well as the gestodent. So those are coming under the same classification, but yes, one group is having more androgenic property and what they are acting more, they will produce more androgenic properties. Well, they are going to produce less androgenic property. They have less affinity towards that receptor. So thereby they will show less acne properties and all. Okay. So that can be the classification. Now coming to the antiprogestins. Antiprogestins, that is your antagonist, progestin antagonist or blocking activity. Now, progesterone antagonists, these are compounds that block the progesterone receptor. So why? They will prevent the action of progesterone in the body. Now, why do we need progesterone? as a blocker. Progesterone, what it does, normally it will help for the development of the baby, for the endometrial protection, okay, for the placenta, for the nutrient supply, everything. Now, if you're blocking, you're giving some antagonist of progestin so that all those processes should not occur, with the mindset to terminate the pregnancy. That is, for the abortion purpose, you're giving this progesterone antagonist. So we are learning about this particular estrogen androgen progesterone antagonist activity. So in this condition, mifepristone, that is something, the progesterone antagonist or progesterone blocking activity. This particular mifepristone, it is given in combination with a prostaglandin analog, that is your misoprostol. These two culprits, what they will do, when they come together, they are going to enhance the termination of pregnancy. They won't allow the proper pregnancy to occur. Okay, for abortion, for that purpose, they are normally given in combination. That is antiprogestin combined with the prostaglandin analog, that is your misoprostol. So this is given normally orally, or you can say intravaginally. So that is one way you are giving as a contraception or to terminate the pregnancy. So that is used as antiprogestins. Now coming to the contraceptive part. Okay, what is contraception? To prevent the pregnancy. It intersects with the birth process at any stage ranging from ovulation to the ovum implantation. So at any stage in this particular part, it is going to break the proper flow of activity for the proper pregnancy to occur. Okay. The first one is the combined contraceptive pills, I pills. Okay. So all these things we are learning about what are different contraceptive methods which can be used. Okay. Now, the OCPs with combined estrogen and progesterone. So this particular combined oral contraceptive, it contains some amount of progesterone derivatives as well as your estrogen derivatives. The estrogen provides a negative feedback on the release of luteinizing hormone and follicular stimulating hormone by the pituitary gland, thus preventing ovulation. The progesterone also inhibits the luteinizing release and thickens the cervical mucus, thus not allowing the sperm to transport. What happens here? Negative feedback, which means what? Normally, the gonadotropin releasing hormone, it is going to enhance the pituitary, that is the anterior pituitary, to produce the FSH as well as LH, right? What happens if there is more amount of luteinizing hormone and follicular stimulating hormone in the blood? Luteinizing hormone, they will give a inverse feedback. Okay, the inverse, or you can say the feedback to the gonadotropin or releasing hormone to inhibit the release of what? The luteinizing hormone as well as the follicular stimulating hormone, or you can say for the reduced production of estrogen and progesterone. So that is something here what? They are going to provide a negative feedback. So thereby what the hypothalamus will do? It will suppress the production of LH as well as the FSH. So thereby there is no estrogen and progesterone produced. It is going to what? Alter the proper hormone balance, and that can act as what? It can help as a contraceptive method. So that is one reason. One side, what is the synthetic estrogen, ethinyl estradiol? What is that doing? It is going to stop the ovulation. It won't allow, or it will prevent the ovulation to occur. On the other side, as a supportive partner, progesterone, what it is going to do? It is going to alter the cervical mucus. Okay, it will make the cervical mucus thick. Okay, so that the sperm cannot pass through that area and reach the ovum for fertilization. It will create a barrier by thickening the cervical mucus. Okay. Thereby, that is the activity. So this progesterone, it is doing one activity is what? They are thickening the cervical mucus. On the other hand, they are also inhibiting the luteinizing hormone secretion. I mean, that production is suppressed by progesterone also. But the major factor is through where? That is, they are going to have the negative feedback mechanism. Now, what is the action? What is the, how this particular contraceptive can be used? Okay. Started on the first day of the menses and continued for 21 days following by a 7-day withdrawal period to allow the menses to occur. We have a 28-day cycle. Okay. In that, the 21 days will be the pill day. You have to consume one pill each day. Okay. That is from when? From the day of the menstruation. From the first day of the menstruation, starting that day, for the 21 days, you have to consume the active pill. After that, for the 7 days, you are going to consume what? The placebo, the dummy treatment. Okay, so you are going to give a placebo treatment. Let's see for this example, the norgestrol, that is what? Your progesterone derivative, ethinyl estradiol, estrogen derivative, synthetic derivative, And these are given for the 21 days, consecutive days. And for the next 7 days, you will give ferrous fumarate as a supplementation. It doesn't have any outcome, the therapeutic outcome, but yes, as a supportive treatment, okay, or as a dummy treatment, placebo give this particular ferrous fumarate. So that is a 28-day cycle. After that 7-day period, you will have the withdrawal bleeding. What is that withdrawal bleeding? It is not the menstrual bleeding. It is when happening when you're stopping that particular usage of the pill, withdrawal bleeding. Don't get confused with the menstrual bleeding. Okay, after that 7-day withdrawal period, it will occur, and that what to allow the menses, the blood flow to occur. Okay, so that is the process here. So in this, you see with oral contraceptive as well as the without oral contraceptive. Okay, that process, that is what actions is the progestin and estrogen showing. So they are going to what? Thinning of the endometrial lining. They won't allow for the implantation of this fetus in that embryo to get embedded in the endometrial lining. Why? They are going to make that endometrial lining thin. That is one factor. And then they are going to thicken the cervical mucus in the cervical region. Okay, estrogen, those both are what they are going to do. They will prevent that egg from moving through the fallopian tube and reaching the endometrial layer for the embedment. Okay, so that is the action. So the first one is the combined oral contraceptive. Second one is the transdermal patch. So it contains same ethinyl estradiol as well as the norelgestromin. Okay. Now what is that? It's a transdermal patch which is placed where? In the skin. Transdermal administration of the drug. So that is a 3-patch system we have. That is, apply 1 patch for 3 weeks. That is for what? Same 28-day cycle. For the 3 weeks, that is for 21 days, you are going to apply this particular patch on the arm, upper arm area. You are going to apply, and then each patch the same day of the week. You have to, whenever you are applying for the 3 weeks, every week you are going to apply this patch, right? So you have to apply on the same day of the week. And then you will have 1 week which is the patch free. So during that 1 week period, you will have this withdrawal bleeding. Okay. Now, what is that composition of this layer of this transdermal patch? We have that one sticker area, the adhesive area, that is called the release liner. So that is removed at the moment of the application, and the inner part, when the adhesive sticker part is removed, the inner area, that is the medicated adhesive layer, which contains what? Your ethinyl estradiol and norelgestromin. Okay, and then the outer area, the upper outer area, why? For the protection. So that is something, the polyester layer. From damage, from any kind of damage, you are protecting that particular transdermal patch through the outer protective polyester layer. Now, mainly this is particular something, it can be applied in the upper arm, like outer arm, then buttocks area, lower abdomen area, torso area, except the breast. Breast area should be avoided. Apart from that, the upper torso area, in all those places, you can apply this transdermal patch. Okay. So that is another way of contraception. The third one is the vaginal ring, Nuva ring, you can say. So that is something, see, it's a plastic, a kind of latex-free plastic, okay, like compressible type of plastic we have, which is inserted in the vaginal area. So they are blocking that particular area, okay. So it is made up of a latex-free plastics, contains both, progestin as well as ethinyl estradiol, both are there, combination contraceptive it is. Then that is also this particular ring, it is also worn for 21 days, and then for 7 days it will be removed, and then the withdrawal bleeding occurs. Now what happens if this particular ring, if it is inserted for more than 4 weeks? Normally for 3 weeks it's there, the medicated part is there for the 3 weeks. If it is still there for the 4 weeks, it is of no use. Okay, and if you forget to take it out after the 3 weeks, the medication won't have any support for this prevention, and then you have to go for what? For some other contraceptive methods, like the use of condoms and all. Okay, some other contraceptive methods. So backup, that is something, the backup contraception. If it is placed, this ring is placed for more than 4 weeks. Okay, so until the new ring has been in place for the 7 days. So that is some of the important consideration you should give by using this vaginal ring. Next, all these 3 topics which we have learned till now, there we had the combination of progestin as well as the estrogen derivatives for the contraception. This part we are going to learn when we are using the progestin derivatives. There is no use of estrogen here. Okay, so in the patient who is resistant to the estrogen supplementation, okay, they have some kind of cancer, breast cancer, endometrial cancer, if they have some other factors which is side effect of estrogen, if you cannot give estrogen in that patient as a contraceptive, then you can go for the progestin derived contraceptive methods. Under that, the first one is the POPs. What is that? POPs, mini pill. Mini pill means what? The progesterone only pill. So that is the other name, that is the mini pill, and that is what it is, containing only the progesterone derivative. This pill should be taken continuously without interruption from the beginning of the course. Unlike the other factors like transdermal patch, the vaginal ring, which has been placed for the, for the 21 days, this you have to consume without any interruption, without any, change in the timing or the date. Okay, from the beginning of the course, you have to consume. The adherence should be there. The patient compliance should be there. It also acts as an alternative when the estrogen pills are contraindicated. That time you can go for this mini pill. So what it does, they will alter the cervical mucus area, that same process, okay. They'll prevent this entry of sperm, so they cannot reach the ovum for the fertilization, and they won't allow for the implantation of those fertilized egg also. Duration throughout the menstrual cycle, and what are the example? Norethindrone as well as the norgestrol, or you can say the mergestrol. So that is something you're giving, which are the progestins only. Okay. So those something progestin, mini pills. Coming to the next one, that is your injectable progesterone. So it is an injection that prevents the pregnancy in the way it inhibits ovulation. One point, they're going to prevent ovulation. They will change the cervical settings itself. They'll change that area, which is helping for the sperm to reach that particular ovum, okay, for the unite, so that they can unite together. So we are going to prevent that, and change in the uterine lining. So they are going to alter the endometrial lining so that the fertilized egg don't get stick to that area. Okay. So thereby, we are not allowing the fertilized egg for getting implanted in that particular area. So that is, you are going some injectable progesterone, which is given intramuscularly and subcutaneously for 3 months. Now, this is something which is a potent type of contraceptive methods, okay, which is long acting also. And also, if your body is tolerant to this particular injectable forms, you can continue the use of this contraception for 2 years also. Okay. So that is the use of this medroxyprogesterone acetate, used as an injectable kind of contraceptive method. The mechanism of action is similar to all this particular classification, okay. What is the action of progesterone? The derivative of progesterone. What all actions it is mentioned, those are similar for all the other contraceptives. Okay, just keep that in mind. Next, progesterone implants. You can see here one implants, one small rod-like structure it is there, which is placed inside the cell. Inside the arm area, down part, in the inner part of the arm. Okay, so you can say implant which is made under the skin, okay, in the under the skin region. So that is something which is going to have this progesterone derivative itself. They don't have this estrogen derivative. So it's a single small rod implant that releases the etonogestrol, which is what? It's a progestin. So that prevents the pregnancy for 3 years. Long acting. Okay, the injectable forms and this particular implants form, they can be given for the long acting contraceptive method also. Now that is the measurement, that is 4 centimeter long, as well as the diameter will be 2 millimeter. Next, they provide long acting, highly effective, controlled release, reversible contraception. Which means what? Once you remove this particular rod, your normal menstrual cycle will come back to its normal state. Okay, your hormone will get balanced, you'll get the proper normal menstruation and everything. So that is something, your reversible contraception. Non-biodegradable and progestin-only. So these particular rods, these are non-biodegradable. So after a certain period of time, when you want to conceive, you should remove this particular rod from under the skin. Why? It is non-biodegradable. So you have to remove, and then if you're wanting to have contraception again, then you can implant it again, the new version. Okay. The rods are implanted surgically in the upper non-dominant arm area. Okay. So that is something, your progestin implants. Now, IUD, what is that? Progestin IUD, intrauterine devices. So under that, we have the levonorgestrol. So those are something T-shaped structure, similar to that of your copper T. Okay. So these are something, the T-shape, you can see here one T-shape IUD, which has been placed in the intersection of this particular fallopian tube, so that the ova, which is released from here, it does not cross this particular area from fallopian tube and reach the uterus part. So for that prevention, you're going to keep a copper T in that particular area. Okay. So that is something, your T-shaped device made up of what? Polyethylene frames. It is something 32 meter in horizontal and vertical direction. That is something the dimension of this particular the T-shaped hormone IUD. Next, these IUDs make the cervical mucus thick so that the sperm from this area, it doesn't reach that particular uterus part. That is the first action. Why? Because they have this progesterone derivatives. Suppression of ovulation is seen and it prevents the survival of the sperm. It prevents pregnancy for about 5 years, long acting. You can just insert this and it will give you a contraceptive value for about 5 years. Okay, they'll release a small amount of progesterone that is evenly spread in the uterus area, and then they'll show this action. What is the progesterone action? Now, it also suppress the endometrium as well as the ovulation. All the similar mechanism of action is there, but only there is a difference in the, what all different types of contraception. Okay. Coming to the emergency pill. This is something known as the morning after pill or simply a backup pill. Okay, you cannot use it for every time like other contraceptive methods for daily purpose. No, this is something for like unprotected sexual intercourse. Okay, you have gone for an unprotected sexual intercourse, and to prevent the chances of getting pregnant, you're going to give this emergency pill or the backup pill, or you can say the morning after pill itself. So it is a method of contraception used as an emergency procedure before menstruation is missed. As soon as possible, if you consume this emergency pill after you have a sexual intercourse, unprotected sexual intercourse, it will show its action in a faster manner. The faster you take this drug, the faster it will, it will prevent the pregnancy if it is there. Okay. So to prevent the pregnancy following the unprotected intercourse or expected failure of any contraception or expected failure of any condoms. Okay. Also, it is known as what? Morning after pill, post-coital contraception. Post-coital means what? After the unprotected sexual intercourse itself, you are consuming this pill. So, if already the fertilization has occurred, this particular pill, it is not going to, stop that fertilization to grow, that embryo to grow. If already there is a fixed pregnancy, this particular pill cannot prevent it, okay, for the growth. But if there is no pregnancy yet, and you're trying to you're just preventing so that the pregnancy don't occur, for that you can go for this particular post-coital, which means what? After sexual intercourse, you're taking that particular pill. Next, secondary contraception. It is not the primary contraception. Okay, it is just a preventive measure or as a supporting treatment, so that as soon as you have undergone a sexual intercourse, just prevent it with the help of emergency pill. Now, what is the characteristic? See, it is a one-time procedure and not a routine approach to contraception given post-coitally after the sexual intercourse. So under that, we have two categories. That is the hormones pill related. The first one, we have combined the estrogen and progesterone pills. So it contains ethinyl estradiol as well as a progesterone derivative. Now, it should be taken within 72 hours of unprotected intercourse. 3 days. Okay. If a person had sex today, within this 3-day period, you have to take this particular pill, okay, to prevent the pregnancy. Okay. That is the action. Levonorgestrel, it can be given alone also. Why you're giving it with estrogen? To enhance the effect, okay, and also to prevent some kind of estrogen receptor side effects. Okay, that is your cancer-related problems. Now, partial agonist, antagonist of the progesterone. A selective progesterone. So this is something what? Selective progesterone receptor modulator, SPRM. So here, there we learn selective estrogen receptor modulator. Somewhat similar action. Here they are going to modulate the progesterone, agonist and antagonist activity of this progesterone. So a selective progesterone receptor modulator, it is an agent that they'll act on the progesterone receptor, and then they will either mimic the activity or block the activity of progesterone. Okay. So like they are going to either show the full agonist and full antagonist activity in the different receptors in which they are acting. Now, ulipristal acetate, that is a type of the SPRM. Ulipristal acetate, it is also a type of emergency pill. This particular emergency pill, it should be given within 120 hours. That is accordingly 5 days. Okay. So it will be useful if you consume within that 5 days, if you are consuming to prevent the pregnancy, the upcoming pregnancy. So for that, you can go for this ulipristal acetate. For 5 days of sexual intercourse, they'll give you a preventive measure. So that is something, your ulipistryl acetate coming under the SPRM. That's all about your progesterone part. Coming to the third part. So we have learned about the female section, that is over. Now coming to the male part, that is androgen. We all know it's a potent kind of, or the main sexual hormones in the male body. Okay. So androgen, that is what? The main androgen is what? Testosterone. So that is something which is mainly in a larger concentration, it is produced in the male body. In a small quantity from the ovaries also, androgens can be produced. Keep that in mind. Okay, so God has given everyone somewhat all the, features. Okay, testosterone, androgens is there in the female body, and in the male body they have the estrogen and progesterone also. Now they are in the men, it is mainly synthesized by the Leydig cells. Okay, in the testes or interstitial cells of the testis, by the influence of the interstitial cell stimulating hormone, okay, of the anterior pituitary. So from that also testosterone can be produced, and in the larger amount from the testes, that is from the Leydig cells, it is produced. Small amount from the ovaries, that is the thecal cells. Adrenal glands also will help for the production of this testosterone or androgen. Now what is the feature of this testosterone? Okay, so here you see you have a hydroxy and methyl group. These are the unique feature of this testosterone. Okay, they have a unique group also attached to this particular structure. Okay, now masculizing effect of testosterone, that is development of male secondary sexual characteristics and the maturation of the reproductive organs. That is a most important point. That is for the development of the male secondary sexual characteristics. That is your deepening of voice, muscle build-up, facial hairs. Okay, you will have this Adam's apple. Okay, there's a curvature in the neck area, that is the Adam's apple. Okay, so that is all the developmental factor which is in the effect of what? The androgen. Apart from that, anabolic effect. So this particular testosterone, no, they can enhance the protein synthesis. They will help to develop the protein, muscle buildup in the body. So that is something, the anabolic effect. So they will promote the protein synthesis and they will increase the muscle mass. That's why the males have a muscle buildup in their body. Why? Because of the more protein synthesis in their body, and that is going to increase the muscle mass. Why? Because of the anabolic activity of this particular sex hormone. Coming to the classification, we have natural, synthetic types, and then we have one anabolic steroid part. Natural, that is your first main important is what? The testosterone. So that is something which is derived from the testis, and we have DHT, that is testosterone. It is going to derive one another important kind of sex hormone, or you can say derivative of androgen, that is the DHT, 5-alpha dehydrotestosterone. So those things which are produced from the testicle part, then from the adrenal cortex, these two are the weak androgens. That is the androstenedione. So this is a precursor for what? In the first slide I have told you, right? Androstenedione, it is the precursor for the production of the estrogens also. Okay, not only the testosterone, but for the estradiol, estrone, as well as the estriol. For that also, androstenedione is acting as a precursor. Okay, so that is also a type of weak androgen. And then we have the DHEA, dehydroepiandrosterone. DHEA. Okay, so these are the normal type, natural types of androgen. So they will have the natural activity of androgen. But now we are going to enhance that activity by having some synthetic androgens. So that is something, your methyl testosterone, fluoxymesterone, propionate, as well as the enanthate. Okay, these are some of the your intravenous version of this particular synthetic androgens. Okay, enanthate as well as the propionate. So those are some of the synthetic androgen to enhance the activity. Okay. Next we have the anabolic steroids, that is nandrolone, decanate, oxandrolone, stenozolol, as well as the ethylestrolone. So that is something, the anabolic steroids. Why do we need steroids? Normally the muscle builders, the weight gainers, or you can say the gym trainers and all, the people who are going for this, the muscle buildups and all. For them, the males, they will have this muscle enlargement. Why? They are consuming some kind of steroids, the anabolic steroids. What they will do, they will improve the wasting syndrome. Improve the wasting syndrome means what? The wasting syndrome means what? They are going to be, reduce in the body mass. Okay, so we are going to act the opposite way by giving the anabolic steroids. The muscle builders, all those people, what they are going to do, they are misusing it so that they can develop their chest, they can develop their muscles. Okay, for show off or whatever activity they are doing. For any kind of Olympics, whatever it is. Okay, for that this anabolic steroids can be used. Okay, so they are going to enhance the muscles in the male body. So that is also one derivative. Now coming to the anti-androgens. So estrogen is one type of anti-androgen. It's the opposite thing, right? Estrogen. So there's a high amount of estrogen, androgen level is less. What will happen? The males, they will have the females' characteristics in their body. Next, testosterone synthesis derivative, ketoconazole and spironolactone, antifungal, potassium sparing diuretics. So these are also going to suppress the androgen level in the body. Next, directly androgen receptor antagonist, flutamide, bicalutamide, cyproterone and spironolactone. So for the prostate cancer and all. So if there is more androgenic activity, there will be proliferation of the cancer cells, prostate cancer and all can occur, right? So for the prevention of that, you can go for this particular antagonist, that is your flutamide and all, okay? And we have 5-alpha reductase inhibitor. For the conversion of testosterone to 5-alpha, that is from testosterone to the DHT, this particular enzyme, that is the reductase enzyme, is important. 5-alpha reductase enzyme. So we are going to inhibit that particular enzyme itself. So the conversion of testosterone to the more potent form, that is DHT is the more potent form of testosterone. So that can be prevented. Okay, so that for that finasteride as well as the dutasteride can be given. Okay, even for your benign prostatic hyperplasia. For this condition also you can go for this 5-alpha reductase inhibitor. Okay. Now coming to the anabolic steroids. So these are what? The synthetic androgens. They have higher anabolic part, but they have lower androgenic activity. Okay, nandrolone, oxymetholone, and stenozolone. So those are something what? These are also the synthetic androgens, but yeah, they are going to enhance what? The protein synthesis. They are going to have the increase in the anabolic activity. Okay. What is the action there? Testosterone, it is converted into the DHT, dihydrotestosterone, with the help of alpha reductase enzyme. Okay. Then what happened? There will be increase. This DHT, because of the increased amount of DHT, it will increase the synthesis of that DNA, RNA for what? For the protein synthesis. With the help of this transcription translation process which is occurring, right, for the conversion of DNA, then mRNA, from mRNA to protein synthesis. That is something for that this particular the 5-HT can be helpful. And after that, what, because of this protein synthesis, what will it do? It will give a gift to that particular muscle, that is for the growth of muscle, bone, skin and hair. And then apart from that, they are going to have a negative impact. They will close the epiphyseal layer of the bones. So they'll have a stunted growth because of the use of this particular anabolic steroids. Okay, so that is about one important point. For the muscle buildups and all, there are the athletes and all, they are misusing this particular drugs. What are the side effects of androgens? Amenorrhea. What will happen? The the irregularity in the menstruation. Okay, androgenic effect in the woman. So this is something which is happening in the female body. Okay, amenorrhea will be there. They'll have androgenic effect in the female body. That is what? There will be breast size will be there. There will be in the female, there will be decrease in what? The libido. Okay, they will have if there is a more amount of androgen in their body, they will have a male pattern baldness, or they'll have a deepening of the voice, aggressive in nature. Those are some of the things if the androgen level is more in the female body. If it is less in the male body, what will happen? Decrease in the libido. Okay, gynecomastia, all those things will be there. Okay. Hirsutism, weight gain, etc. Hot flashes, the thermal regulation will be impaired. Okay, so because of that, hot flashes, sweating and all can be seen. Night sweats can be there. Cramps, abdominal cramps can occur. And finally, the loss of libido. Sexual drive will be completely lost because of this normal hormone imbalances. As I have told you, anabolic steroids, these are misused, okay, by different athletes and all, okay, for the body build-up, okay, for the gym trainers. So what they are doing, they are enjoying the reputation for improving the athlete performance. So that anabolic steroids, these are misused for increasing their body mass and all. So when combined with adequate exercise, the muscle mass is increased. So those are the exandrolone as well as the oxymetholone. So what are they going to do? They are mainly going to strengthen the muscle. They will help for weight gain, for reducing the wasting syndrome, where there is a weight loss as a side effect. Okay. So for that, they are going this anabolic steroids, and they are going to improve the overall sport performance. Okay. So that is the, the use of this anabolic steroids in case of some people, that is some athletes. Okay. So yeah, thank you for your time. We have completed this estrogen and androgen chapter. I hope whatever I have taught you, it's clear for you guys. Okay, it's a small topic, but yes, important portion. In this particular topic, we have what the anti-estrogen, anti-androgens, all those activities, what they are showing, and yes, what are the, activities of this normal estrogen also. Okay, what are the activities of estrogen, anti-estrogens? Okay, the derivatives, and the most important part, the contraceptives. Different type of contraceptives, how it is like processing in our body. All those points are important. Okay, so yeah, I hope it's clear. So that's all for today. We'll meet in the next class with a new topic. Okay, until then, thank you and have a nice day.